finalized, getting them ready to run for the export of de-identified data sets that will then be aggregated, giving us even more information on convalescent plasma. We're starting to see a lot of novel visualizations that are going to help us answer things like back to work. And of course, the bulk of today's meeting, a 35-minute panel on the topic of back to work with Athena and Intermountain and Merck and Rush, because trying to figure out what does the data show us? What are the infection rates? And what is the right time for us to balance the risk versus the reward of reopening? And without making any political statements, we're just trying to ask ourselves, what are the best practices? And what does the objective data show throughout the country? So it'll be a week of data. Now, one of the things we'll also hit next week is the major advertising campaign on convalescent plasma. And so multiple celebrity endorsements, television and web, encouraging people who have had COVID to use a standard process through the fightisinus.org to go through a plasma bot and then to find a donation center for convalescent plasma or hyperimmune globulin or other blood products. And the timing, of course, of all of our efforts has to be respectful of everything else that's going on in the United States right now. And so I look at the last week as very focused on being respectful to George Floyd and all of the activities around George Floyd's death, as we then also have to start moving back to work. And it's required a lot of juggling and a lot of agility on a lot of people. So we'll move into next week into that bit more awareness on back to work data and convalescent plasma activity. So those are the themes, but Jay, your comments.
Thanks, John. And as always, those are exactly the right themes. And I agree with exactly your schedule for what's happening both this week, this past week and next week, and what's likely to happen. In addition to having a theme of data, I will just add that the other theme that is always part of the coalition is the concept of sharing transparently and urgently. We don't delay sharing. When we think we learn something or we think we know something, it is the coalition's agenda to share it broadly with everybody and anybody. Nobody gets to hold on to a little nugget of information as if it's their special sauce or their special advantage. We share early and often, and as we learn, we share what we learn as well, including things that have changed over time. And one of the things that the other theme I would say about this particular pandemic is it has been very dynamic. Things change on almost daily basis. What we thought we understood and knew yesterday may be different today and may be different again tomorrow. And it is the coalition's mission to give everybody updates on what we learn, what we know, and how that changes over time in a dynamic fashion. And so as we think about the next phase of this pandemic, where NPIs are being relaxed in all 50 states and have been for a couple of weeks now, and the economy is beginning to shift back into gear. Employees are returning to the workplace. Various organizations are restarting businesses that may have been shuttered or closed down or at least slowed down for the past 3 months. Big things will happen as a result in perhaps unpredictable ways. So what do we need to think about in terms of getting back to work and entering this next phase with COVID-19, and what do we learn from it? And as always, we call upon the experts, we call upon the data and the evidence, and we share what we know and share as we learn. And so that'll be the theme for today's series of talks. And I see that our moderator has just returned from clinic, just in time, FX Campion. So without further ado, I will turn it over to FX to introduce the first panel and get us started. Thank you.
Thank you. Well, fantastic. Thank you for getting started. And indeed, the office practice is heating back up today. I saw a mix of face-to-face patients and telemedicine patients, and it was a hopping place. So thanks for letting me join you today. And we have a dynamic panel in store, and what we're going to do is hear a little bit from each organization: Athena Health, Intermountain, Merck EMD, and Rush University Medical Center. And then we're going to have conversation among the group. So our big picture conversation is back to work with COVID-19, and we have a mix of healthcare provider organizations and vendors or participants in our healthcare community. So the goal here is to learn from each other, discuss some of the challenges that we're all facing, and some of the pathways toward care for our patients and for our communities. So without further ado, what we'll do is we'll take in that same order, and we'll start with our colleagues from Athena Health. So I'm going to let the speakers go ahead and introduce themselves, tell us a little bit about their role in their organization and in this plans to return to the next phase.
Excellent. Should I just jump right in?
Yeah.
My name is Bridger McGaw. I'm the Director of Global Security and Services for Athena Health. I've been here I don't normally spend my time in the Millennium Falcon, but it's much more attractive than the curtains behind my desk here at home. I've been with Athena for about 7 years. Prior to that, I was in the Department of Homeland Security, in the Defense Department, the White House, and the Clinton and Obama administrations. I had the good fortune, and I guess I should just start off by saying thank you to all of you. You're really doing the revolutionary work, and those of us in the emergency management, security professions, business continuity, we're relying on you as the subject matter experts to really bring to life all of your work. I spent my, I think, second month in the Obama administration doing the 2009 pandemic, and so my thinking has been sort of preloaded with planning for the worst, I guess. And so I like the theme of today and using what the data shows us, and I'll try to talk through that. So we've been, I'm leading the return to the office. So I guess what I'd like to start with by saying is all of us have actually not stopped working. So it's really hard for people to hear like back to work or back to the office, because technically all of us in the healthcare profession, we've all not stopped. Athena hasn't stopped. We implemented our business continuity plans, and in a day, 100% of us were working from home, and then we brought back 100 essential personnel, and they've been in the office. I have 10 sites around the country and the world, and they haven't stopped. And I know you guys haven't either. So what we talk about, and what I'll try to stick with, is transitioning back to the office, meaning how do we get people back in the office in a safe and healthy way so they can continue serving the healthcare community on the front lines, because this thing is dynamic and it's not going away, and we need to make sure we stay healthy so we can support it. So next slide. So as we thought through how we were going to think about this, I want to put a pin in the whole urgent transparency theory, which is I called every single security officer I've been working with for 10 years. Like, we all have our own informal network. No one's done this before in a night. So and we're all still working together, biopharma, IT companies, defense industrial base, we're all sharing best practices as fast as we can learn it. Oh, I deployed that temperature screening idea. That was a terrible idea. Here's what I learned. Or here's how we did it well. But when we got down to it, we took all the best thinking that was out there that was immediately available. Like McKinsey had great content. So, we thought through, what are the phases of this? Our initial response, how do we implement continuity? How do we return our operations to scale? And how do we achieve whatever that new normal is? And we knew all along, all of those things were going to be defined by the public health community and the CDC and the experts in infectious diseases. We weren't going to define that. We were going to be listening and using that data as it came. So right now, we sort of define ourselves as in a phase of between 2 and 3. So we've established continuity and where we are now, but we're trying to return to scale and move into that new normal. So we identified these 4 main buckets. So if we were going to in order to plan, we broke out safety of our employees, how do we support our clients, all of you? How do we make sure that the worksite logistics were in place, whatever the decisions were from the health community, how are we going to implement those on the ground? And then assuming something bad happens, and something bad will happen, what were we going to do to contain it and bounce back, adapt, and move forward? So we started this process in early April. So we were going with a 2-week rolling strategy of let's see if we can come back, let's see, and then gradually we have pushed out to September 8th. So we have work at home in place through September 8th. Took the pressure of the system and all the employees' angst out, and got them to focus on how we do this safely and healthy, in a healthy manner. Then we broke ourselves out into these 4 groups. The purpose of that was to create what we already knew, and again, urgent transparency. I want to give credit to the group of about 50 critical infrastructure companies that all said, what are the principles of which your executive teams are making decisions? How are they thinking through, and how are you as a security person, how are we advising them to think through that? Because in many cases, your security teams or your continuity folks, sometimes HR, like we connect all of these little cultural nodes across the company in ways that aren't readily visible. So we built these focus groups in order to, next slide, help create these principles. And this is how we use the data. So we had about 50 people from across the company in those 4 groups. We gave them blank worksheets to unpack those questions that you saw on there. What measures, protective measures, did they want to see? We gave them no rules, meaning you can use the CDC guidance all you want. You can use whatever you can find, but like come up with strong opinions about how you think we should think through this. And these were the principles that we have 10 of them here, and the first 5 are really important to us in coming back in our transition. So we have core values in our entities. Let's celebrate them and live them. Everyone spent a lot of time talking about your organizational core values. Use them. And that drove us on that healthy, keeping people healthy. Then we wanted to recognize the dynamic. These themes today are awesome for this stuff. So we knew the threat is dynamic. Therefore, we were going to pace our efforts to be dynamic with it. We were going to adapt. And as it adapted, our third one, we were going to be open, frequent, and responsive in our communications, both to our clients and our employees. If something changed and we changed our direction, we were going to communicate the new direction. Speed helps, right? And it's hard, but we have this. The team I have is on 7 days a week monitoring this stuff so we can be responsive. And then we aren't going to listen to the noise. We're going to stay focused on the best medical, public health, and government guidance and the data. And you've seen that, obviously we're part of this partnership, so we believe that very strongly. That has helped us. It's also problematic from where we sit right now, right? Because asymptomatic on Monday with the WHO giving a press conference, and then just kidding, maybe we weren't right. Are we right? And so there's still some challenges of trying to make decisions on any of this stuff quickly. And the final is we're still trying to protect people's confidentiality. So how do we not just accept great new app number 5 and deploy it and make everybody give us their HIPAA information? Next, their PHI. Next slide. So we called out the noise too. We said, in order for us to be true to ourselves, not just the values, but we got to make sure that we're in Texas right now. We're in Austin, Texas. So if Austin closes down again, we're not going to open. We're not worried about the economy per se. We're thinking about our people. And so dissociating those two things was really helpful. Productivity, we did an employee survey. I highly recommend, if you have not surveyed your employees, you should do that, and you should be prepared to do it frequently. And then we also recognize in these last 3 that this was an ongoing dialogue. HR, each office had its own threat environment, and that would be unique. And then our collaborative culture as organizations and social beings was really going to be hard to replicate, and we were going to have to take some time. So next slide. We're a tech company. We deal with a lot of engineers like zones. I tried to create take all this facilities information, which is really not sexy at all for return to the office, and think about breaking the data down into zones. So far, that's really resonated with engineers because they're like, oh, talk to me about my zone. And that's been helpful. So I've been trying to, all of our efforts are broken down along these big buckets, and it's allowed us to organize all of the regulatory information, which is changing. India has changed its point of view basically every other day for 2 weeks. As a result, I just have a table and I just swap out the guidance for whatever that measure was. But by organizing our data along these zones, if the medical community says masks are required, it's easy to see where do we need to tell people masks are required. And if it says more hand sanitizer or it says temperature screening required, it's easy to understand where those seams are in the protective process so that the workplace can still feel like I understand what I'm going to receive when I come to the office, what is that experience going to look like, and how am I going to still be productive at the workplace. Next. So there's not enough time in the day basically to plan, react, adapt, and repeat, and I just wanted to share that with you. We've tried to identify all the risks we can, but this is an ongoing daily effort to stay on top of. So I think there's going to be a lot of burnout as we go through this, and so we're trying to train a lot of people to be mindful of what's going on, and we're doing extensive surveying on this matter. So we have great data on that front, which will help, and then we're all adapting this ultra marathon sort of approach, which is you're going to set the table for us and help us understand the threat and the problem and what we're learning, and we're going to try to take that information and make it digestible and make smarter decisions off of it. I hope that's helpful, and I look forward to the future conversations that we have today and anything else I can do to help you.
Bridger, thank you. I think we're going to have some questions certainly about the concept of the zones. That's something we're hearing more and more about work environments. We're going to hear now from Tamara Moore. Tamara is a physician at Intermountain Healthcare in Salt Lake City. You heard her speak on this webinar series about a month ago about some of the impressive work they're doing at Intermountain related to testing and making sure they use their testing resources for COVID efficiently. But she's also involved with a lot of the efforts in her organization to come back to full operation. So, Tamara?
Thanks, FX. We're in a unique scenario right now because I don't have any power in my house. So it's nice to see everyone. And Dr. Cutler is going to share slides while we talk it out and engage in this discussion. It's a very large honor to be welcomed back to MITRE. And again, my name is Tamara Moore. I am an emergency medicine physician, and I am the system lead for our technical response to COVID testing, ordering, and workflows. I also have Dr. Lepansry with me, who is our chief of microbiology, and Dr. Catherine Cutler, who's our lead for advanced decision support. Catherine, or is anyone seeing Catherine's screen? I'm not.
I see her screen.
You see her screen?
Yeah.
I don't.
Actually, no, I don't see her. I see her on. I don't see her screen.
Okay. Well, we will take, oh, there we go. Thanks, Catherine. Awesome. Okay, so to just put some background in it, so for folks who don't know Intermountain, so we're a group of 24 hospitals and over 100 clinics. We have 6,200 providers, and we provide 50% of the care for the state of Utah. Since we have started participating in the COVID response in March and until now, we have done over 125,000 routine tests for our state, 7,500 rapid tests, and we've provided over 50% of testing for the state of Utah, which is a lot. And as we started off initially with our testing strategy, you can go to the previous slide, Catherine. As we started off with our testing strategy, we, of course, initially focused on our symptomatic patient populations, our patient populations that might provide risk to our healthcare teams. And as we have, quote unquote, returned to work, our normal business and healthcare operations also increased in volume. And over the past several weeks, we have experienced a surge in our surgical volumes, returning them to relatively 100%. Currently, national surgical guidelines and leading healthcare organizations have the perspective that pre-procedural testing is an intrinsic portion of returning to surgical practice in a pandemic setting. And so we've had challenges and problem solving around how do we ramp up testing to a significant portion for our pre-surgical populations and manage that workflow. It's a bit of a philosophical challenge because we need to provide pre-surgical testing currently based on our knowledge of COVID. We have to also balance turnaround times and the knowledge of, okay, if we have a turnaround time for a routine test of 3 days, when does the patient actually get the swab in their nose? How can we guarantee the patient will isolate after the swab happens and manage that on a rate of almost 3,000 surgeries a week? And so as we've watched our data from our frontline inputs and monitored, initially when we started testing in March, 100% of our patients were symptomatic with a high risk for COVID. Now our volumes have shifted and we're performing almost 2,500 to 3,000 tests a day, and over 50% of those tests are asymptomatic patient populations, and probably around 15 to 20% of our total volume is pre-surgical testing. And so we have been struggling with how do you manage that dramatically increased volume with a relatively low prevalence that's dynamically changing. When we first started tracking our prevalence rates for these asymptomatic patients without known exposure, they were hitting around 0.1%. But we've slowly started seeing an increase to almost to 0.3%. And we've certainly had a handful of surgical cases that tested positive that would have perhaps put the surgical team at risk. We're not 100% sure. And so we're evaluating those on a case-by-case basis. Another crux of our testing strategy is much of our testing approach has been stood upon a large redeployment pool of folks who were working in surgical services, but then we stopped doing elective outpatient surgeries so they could help us support our testing workflows. And we currently average about, when we're doing our best testing, we can average anywhere from 60 to 120 swabs an hour based on the efficiency protocols that we've created. So a large part of that efficiency, however, is based on our model in March, where we had a lot of more folks. And since those individuals are going back to surgical procedure, we're now learning how to maintain that level of efficiency with less humans. So it gets quite interesting, and it's a constantly changing challenge to keep the patient safe, keep the surgical team safe, and support the necessary things that need to happen to support these patients who have had surgeries deferred, and seeing how things can change. Catherine, do you want to go to the next slide? So in the midst of this, we also have struggled with our use of rapid testing. We currently have rapid testing criteria, as we had revealed a month ago, that focuses on the symptomatic ICU patient, the symptomatic pregnant patient about to give birth, and rapid typically has a turnaround time between 2 to 4 hours compared to our standard of 24-hour turnaround times. And so being able to flex those rapid tests to the patient populations that truly need them, and then balancing that with pre-surgical populations as well, has continued to be a problem that we mull over. Next slide. Bert, do you want to speak about our focus on hotspots?
Sure, absolutely. So as we work diligently to meet the needs of our organization and our patients and our caregivers to get the system up and running again, there remain challenges in the community. And it's pretty clear that there continues to be transmission in certain locations around our state. And while we are ramping up our testing capacity to meet the needs for all these asymptomatic pre-procedural testing, we still have to be mindful about how we can play our role in helping the broader community whenever there are these hotspots that pop up. And one of the things that we've been doing is using our mobile testing unit to supplement the different collection sites that we have scattered around the states that get overwhelmed when there's a rush from local work-related outbreaks. And an example would be a current challenge that we're facing up in one of our northern counties with a work-related outbreak. And that quickly overwhelmed our local testing site. So we had to use our mobile team to help collect exposed patients up there to meet the needs. The public health department is also involved in these hotspot testing, but it gets to the point where the capacity gets overwhelmed, and we step in to try to help out as much as we can. So while we are keeping one eye on getting our operations up and running, we have to be mindful and keep our other eye out on challenges that occur in our community and help our public health partners as much as possible.
Thanks, Bert. So as we have this variation in our responses and we're responding to different hotspots in a wide geographic area, we continue to ponder how we might respond with flexibility for our own internal hospital protocols, our own rates of surgical scheduling, and other asymptomatic screening in the setting of local hotspots. And we're investigating different ways to allow for some regional flexibility, to say, gosh, well, there might be a surge in our very southern region compared to the very northern. How can those local hospital leadership, healthcare leadership partner with their county leadership and their government to set those protocols on that basis? And how do we support them as a centralized testing to flex our testing capacities to those areas that need them? So these are some of the challenges that we are focusing on today. Again, our top priorities continue to be prioritizing our healthcare team, responding dynamically to hotspots, and balancing the rising need of asymptomatic screening coming from all corners of not only preoperative, but close contact screening. There's concerns for screening prior to travel, work-based screenings, and to serve our role in the community as well as we can. We are quite proud of what we've accomplished and continue to provide significantly increasing levels of testing each day and continue to provide greater than 50% of all testing for the state of Utah. Thank you.
Tamara, thank you. That is fascinating. When I spoke to you on the phone last week, I knew the story about testing was evolving rapidly, but to hear about the mobile testing and how you're using it to meet the needs of the state and the community is very impressive. And I expect that, can and should become a best practice around the country. So I'm sure you're going to be asked for more presentations around that particular activity. So congratulations. And we're going to move on now to a story from James Kugler from Merck, obviously one of our important colleagues in the pharmaceutical industry that never gets a day off either. So James, let's hear from you.
Excellent. Can everyone see my screen right now?
Yes.
Perfect. So I should probably start off with a little bit as to who we are. So as mentioned, I'm James Kugler. I look after digital for EMD Group, also known as Merck KGaA, Darmstadt, Germany. For the removal of any doubt here, this is nothing to do with Merck & Co., which is a pure play pharma company in the US that goes by the name MSD everywhere else in the world. We go by Merck everywhere in the world except for the US and Canada, and operate in US and Canada as EMD Serono, Millipore Sigma, and EMD Performance Materials. We're a 352-year-old company. We're the oldest pharma company in the world. Obviously, now we've expanded into other areas. So our three businesses are pharmaceuticals, life sciences, so basically any reagent a scientist needs to do research, all the way up to the manufacturing of biologics and biopharmaceuticals, and performance materials, which is basically all of the materials that you need for electronics, from semiconductors up to display materials. So you're probably looking at this right now on a screen. There's a very high chance, about 80% chance, that the liquid crystals in that screen are coming from us, as well as most of the semiconductor materials and the chipsets that are there. We operate in about 66 countries, and we have about 57,000 employees globally. And we're just over 70% family owned still by the original founding family of the company overall. What's been interesting for us is that the crisis, when it started, we started getting indications very early on from our teams in China. So by early January, we knew that something was going on, and that we were going to need to start acting soon. By the end of January, we had set up a global task force to start looking at how we're going to approach this globally. And quickly thereafter started looking at each region response that we needed to take to this. And so we've had a benefit of being able to learn as the disease has spread, and as the response has had to change over time. When it first started, though, we put together a global team to start figuring this out on a couple of core principles. And for us, those three principles were: one, ensuring the safety and well-being of our employees and their families; two, playing a positive role in public health overall, because we still had a lot of folks that are depending on us, from the researchers trying to do research, through to patients that still needed pharmaceuticals. And third is to sustain our business well beyond the crisis, to ensure that we can keep moving forward in a sustainable manner. As I said, we had kind of this global approach that then fed out into the individual countries. And so for us in the US, we have a United States Country Council that then put together a COVID task force very quickly. And to give you a sense of our US footprint here, we have about 13,000 employees in the US, 35 manufacturing sites, and 62 sites and offices. And so this is spread pretty much across the country. So we've been throughout the process learning from our colleagues elsewhere, and approaching everything in a manner of trying to share as much information as we can between the regions, so that we can see what's worked, what hasn't worked as we start reopening in particular. So we've gone through the reopening process now in Asia about 6 to 8 weeks ago. Europe has been going through this over the last 4 to 6 weeks, and we're now just getting started in the US. Part of this task force that we put together in the US, we put together essentially a framework for how we wanted to approach things. And so each one of these steps here, we have dedicated teams around. We meet probably about 4 or 5 times a week to go through this, and to ensure that we're doing the best we can in each of these areas. But the 9 areas that we're looking at, everything is based upon at least, obviously, the compliance with local guidelines and laws. That's an absolute minimum. And the question is then, what do we need to do beyond this? So the first work stream was around this stepwise approach for redensification. So how are we prioritizing people to get back into the office? What are the highest, lowest risk groups that we have? And how do we further resume operations? To put in context, we've had about 50% of our employees that are essential and have had to continue going into our manufacturing sites. The second work stream was around physical distancing. So how do we do this in production and R&D, looking at the meeting spaces that we have and any of the open space offices that we have, and then also looking at field and sales force activities. Third stream was around specifically protective equipment, so the surgical masks, the PPEs. We have safety kits for private use and for individuals, so employees and employee families. Fourth was around testing. So how do we have a systematic testing approach? How are we doing the appropriate risk assessment screenings and the temperature monitoring at our different locations? Fifth was around hygiene and cleaning. So the general, obviously, hygiene guidelines that we need to follow, signage, those types of things. And also the global facility management preparation. Sixth was around travel and how do we give guidance to all of our employees on traveling, especially the field teams that we have. Seventh was on reporting. So the infected and recovered employees, the home office folks, and people who are affected by COVID-19, maybe outside of the office, and the general compliance around data reporting. Eighth stream is around data management, which I'm going to talk a bit more about in just a bit. And the ninth was around people. So the employee framework, the leadership frameworks that we need to have just to ensure that people are taken care of. So the two ones that I have started here, the stepwise approach and data management, I'll jump a bit more into. Data management is really the one that I think is the most interesting, in part because that's the one I'm working on the most. But just to give you a sense, this stepwise approach for de-densification. So as I said, about half of our employees have already been in the office and working as part of the essential workforce. The next step here is what we're calling our focused vigilance stage, where we're looking at bringing back up to a maximum of 40% of the employees who are working from home to be able to come back to the office. And a lot of the determination for how we do that is really based on providing as much information as we can to our individual site leaders across the country. And so we have about 150 or so site leads that we work with regularly to ensure that they have all of the right information. And even when we look at that list of the 9 different items that we're working on, we have about 150 page document that is constantly updated to provide a framework and a handbook, so to speak, for all of the site leads to be able to bring their folks back in as safe a way as possible. On the data management portion, there was obviously kind of the core basis of this, which was providing up-to-date real-time state and county data. We went a little bit beyond that to say, how do we provide as much contextual information to each of our site leads, particularly since any individual site that we have employees that are coming from multiple areas. And so what is the best kind of mechanism to be able to arm all of our site leads with all of the information that is available publicly, as well as combining that with contextual information on who are the actual employees that are at each of these places. Another thing that we did was we looked at within each given site, we have different spaces. And so there's obviously the minimum requirements that we have. We all know the 6-foot social distancing guidelines, but we wanted to say even beyond that, could we provide additional services to our different sites to allow them to, in a slightly smarter way, think through how these different spaces should be used. And so we had a group of engineers put together a modeling tool for our site leads to use that basically allows them to look at the size of the space that they have, the types of activities that are happening there, as well as the circulation, air circulation that they have in any given space, and start looking at what are the risks over time, given certain numbers of people being within that same space. And so this has been something that we've been really working kind of one-on-one with each individual site to help them plan out. We've also had a contact tracing and proximity alert app that's been in development to be able to use, at least with the folks that we have at the offices on their own mobile devices. That's something that we're targeting for at the end of August. Just to dive a bit into this dashboard that we're looking at. So this information is updated daily. All the site heads have access to it. On the right, you can see kind of the information that is typically available, the public data sources around this. So we're looking at 7-day rolling new cases per 100,000 over time. The different areas here are for one of our sites, the different counties that their employees are coming from. What you see on the left, though, is really the kind of core pieces that have bubbled up in importance for our site leads as we've been iteratively kind of building on this. So what's the percent of their workforce that's in quarantine, the number of employees they have in quarantine working from home, employees in quarantine unable to work from home, the employees they have in the office pre-June 15th, which is when we're starting our next phase of redensification, the employees from home office who have returned to the site, the all-time confirmed cases that they've had, the confirmed cases at the site within the last month, as well as the overall number of employees they have. This one on the bottom left here was one that was found to be one of the most useful ones for us. And what it did was it looked at 7-day rolling new cases per 100,000 as a weighted average over the employee counties. So for any given site, we're essentially creating a weighted average of the infection rate given where all of their employees are coming from. So this was particularly useful in locations that we had that were maybe between sites. So maybe we have a site in Massachusetts where we have folks coming from New Hampshire, or New Hampshire where they're coming from Vermont and Massachusetts, and really taking into account what is the context of everything that we have there. One of the other components was being able to put this in a frame that ensured that everyone was still vigilant. So we didn't use red, yellow, green around it. We kept it as kind of all yellow, that we need to be really on guard. But this is something that's been evolving in as real-time way as we've been able to do. And it's been really, really cool to see, and especially the appetite of our different leads across the country to consume and really use this information in making these decisions. So hopefully that's useful. It's fantastic to be here. This has been a wonderful coalition that's been assembled. And so really look forward to discussing more in the Q&A session.
Thank you, James. That's just fantastic that you're able to describe so much effort from, I'm sure, literally hundreds of people putting those dashboards together and working together. Very impressive work. We've called back Dr. Shafiq Rob, who you met a few weeks back from Rush Medical Center. He shared with us some of the prediction tools they've developed in Chicago. This was very early on, I think back in March we had Shafiq. And Shafiq, we're anxious to hear you tell us how things are going at Rush today and how you're trying to return to the next phase.
Well, thank you for inviting me back. I wish I had slides, but I'll do my best. First of all, Rush University Medical Center is in Cook County. And Cook County has the dubious, we have the largest number of COVID infection in the country, 83,978 people. So that's a lot of people. We have more than New York, any one county. And so when we started our journey, as I've talked before, like our esteemed colleague talked about return to work. So we started with the idea that everybody's back to work, but we have to bring our patient back. So when we started that journey, we were doing emergency patients for outpatients and emergency surgeries that we had allowed. But how to keep everybody safe, that was the number one criteria. Second, in the state of Illinois, we were allowed to resume surgery or bring patients within the buildings if we had 20% ICU bed capacity left for in case of surge. That means at one time, we could not have more than 80% of COVID patients in our ICU beds. So that was the criteria. Second is that within our state, now at this time in the city of Chicago, our doubling rate has gone to 62 days to 63 days. In the beginning, it was 2 days and 3 days and 7 days. So as the doubling rate went up bigger and bigger, the infection rate cannot be more than, is in the city of Chicago today, is about 13.1%. Some places is 16.3%. Based on that, the government allowed that we should be able to open up for surgical patients to return. As you know, for us, surgery is very important because it generates a lot of revenue. In the meantime, we had done a very good job of getting PPEs and putting them into a 180-day trend. That we have 172-day supply of gowns, gloves, and masks, so that we don't run out of it. Second thing what we did is that we also doubled our ICU capacity so that we have enough ventilators if needed. While we were doing this, we also increased our testing capability and capacity. And today, if an employee feels that they don't feel okay, they can get tested immediately. It's not that they have to go through a line or anything else to do that. Similarly, we also looked at our outpatient places or hotspot like shelters, homeless shelters, nursing homes, other places. We sent our mobile unit to go do testing so that we can find out what's happening. While we were doing this, this testing capacity, we found out that some surgical patients they were COVID positive. So we had to postpone that surgery, and we ran through the same problem, is that how do you keep somebody safe for the next 2 days or 3 days so that they can come back for the surgery. While we were doing this, we were opening that, so we had to put thermal scanners for our employees who are returning, who were already there, or increased number of staff to have thermal scanners and temperature reading. But at the same time, when a large number of people came, we had to install bigger thermal scanners that can speed up for people to come in, because individual thermal scanners took a longer time, and that was not feasible. Then we had to make sure that everybody had a sticker of some kind so we know when they were scanned for that day. Then we realized that we had to ask questions. So we put those questions in. Similarly, we send the same questions to the patients before they come to our outpatient. They sit in the car. Then we had to stage an area for surgeries. So United Center is where our basketball is played. The Bulls play there. There is no Bulls playing there. So we took the entire parking lot, and that's where we staged safely incoming patients for surgery and patients being discharged for same day or for longer time, so that there is a safe route. In short, we had to create two hospitals with one hospital, a COVID part and a non-COVID part, so that the entire, from the beginning till the end, there is no chance of any infection, either for the employees or for the patient, to have a clear path so that can happen. While that was happening, the back end offices, that means the IT people, these billing people, they are still at home. Only essential people are coming back to work for us. And as we are going through this process, we had talked about maybe some other time when I get a chance to come back, then I can show you the graphs and other things that we have done for the predictive modeling for that. One of the things that happened to us is that we became the city's deputized city for the city of Chicago to do the capacity aggregation and the CCDA aggregation, so that we understand what is the virus load and what is the capacity load and who has how much capacity within the city of Chicago, so that we can move patients, or the city of Chicago can move patients. While we were doing this, we also found out that there are new labs that do ELR, electronic lab reporting. In that, we have to capture those reporting so that we have real-time data to understand where the hotspots are and where there's less thing. While that was happening, we had a large number of people in Chicago that were affected by the recent happening in Minnesota or George Floyd. That created a lot of people getting together. So we got a little afraid that a surge will come, but we have not seen a surge yet. We are expecting something in the fall. Luckily, by wearing masks and keeping social distance, the numbers are still under control. That is my report. If there are questions at the end, I can talk more in detail if you want to ask.
Well, Shafiq, that is fantastic, and I want to thank you for the amazing story that we heard the first time, and this time it's one of a lot of innovation and a lot of determination, and obviously very talented people that really care for the community. So thank you.
Just want to let you know, FX, we have tested more than 40,000 patients in our area, in our hospital.
That's great. We have precious little time for our panel discussion. We'll take just 2 questions, and then I'm going to ask for Chris Glasner and Joe Ungerleider to give us a quick update on the decision dashboard that's been developed in the coalition. I just wanted to ask a question to the panel just about testing of their healthcare workforce. And one mention was about pretty much on demand. That's evolved rapidly, but just give us your thoughts about testing your workforce, and then see if there's any consensus around that. It's a fast-moving target.
I'll go first. I don't mind. Where are we gonna get the tests? Who's gonna provide them? How soon are we gonna get them? What's the supply chain? You know, how fast can we get them turned around? There are too many questions. There are no answers. There's lots of questions, and you know, for commercial businesses to really, I mean, we debate this with all my security colleagues in other companies. Like, it's just not fair. It's like, what do we? Asymptomatic stuff gets around it anyway. So you either have to test everybody all the time, or you have to be really careful that, like, the health guidance that we're getting from the state or the local public health authorities is really up on their R naught level, you know,
Right.
so that we can feel confident that the percentage of testing that's going on is catching enough of it that we don't have to do a test up every person, but we still can't get the tests. The antibody stuff doesn't work. Everybody's trying to sell us stuff that may or may not be good. I mean, I'm highly skeptical right now.
And Tamara, I know you're a testing expert.
I don't know if I'm a testing expert, but I've certainly had a lot of time with it today, and my power is back on, so that's exciting.
Woohoo!
Yeah, thanks. So at least our approach for testing our healthcare workforce is we still require, you know, a confirmed exposure without wearing the appropriate PPE. So if you're in an aerosolizing generating procedure, but you're in a full PAPR, I mean, we're not going to test you. We're going to assume that PPE wasn't breached, but we have a very aggressive employee health program that we've stood up that reviews potential exposures with each individual employee. They're available on a 24-hour basis. We bundle our healthcare worker exposure with our general patient population exposure criteria as well. And we, of course, do provide very rapid and prioritized testing of our healthcare with our intrinsic CDS-based algorithms that we talk about. So healthcare worker tests don't necessarily get the 2 to 4 hour turnaround times, but we certainly do them in our top shelf compared to the general folks so that they can continue to care for our patients in a safe manner. There's a lot of fear that PPE doesn't work, but if you have the right PPE, you should be okay.
Good. Okay, well, I think we're actually going to wrap that as probably the last question and ask Joe and Chris Glasner to come on to give us an update on the decision dashboard. This has been a great evolution over the last 10 weeks. Chris or Joe?
Certainly, yeah, I can take it. So I'm Chris Glasner. Joe and I and many others have been working for the coalition to bring a lot of data and analysis to support decisions. At dashboards.c19hcc.org, we've consolidated all the analysis that we've been doing over the course of the outbreaks. We've put it all in one place. So there's a lot more here than probably the last time you've looked at, including, you know, some stay-at-home analysis, NPI analysis, the models we've built, a new hotspot identification feature down to the county that also allows you to forecast hotspots going out in the future. The big work, however, to make you aware of is the work on the COVID-19 decision support dashboard. So this dashboard takes all the data and analysis that the other team did and really tries to pull it together in a single spot so you can really do some detailed comparisons to ask what type of decision should I make, where are we on some key metrics. You can, you know, navigate down to the county level. I have you know, my home county, Fairfax County, highlighted. It'll also identify similar locations. So it says Montgomery County is very similar demographically, so you might want to compare it to that. Or maybe we want to look at DuPage County in Illinois, just outside of Cook County. And so as you do that, you can star counties to make your favorite. You can come in and then compare those areas on key metrics, you know, looking at what is the status of the outbreak, looking at your case trends, looking at diagnostic testing. If it's available at the county level, it's often not. You have to go to the state. Looking at the real-time reproduction number, the RCT. So you can compare the different areas and then get guidance to say, are you too high? Are you kind of in a warning zone, or are you in the green? You always give the source for all the information in the source. So we've got the trends and deaths. We've also got social mobility in here, because I think a lot of people are trying to understand what is the trend. From analysis that we can tell you, transmission follows mobility. That's probably a better predictor than many other things. So this is actually good. So it's not as good that in Illinois you see mobility being much higher than you see it in Fairfax and Montgomery County. And then we're bringing in forecasts as well. So this is looking at the demand for N95s in different areas, because many people have reopening criteria based on a PPE availability. So every 2 weeks, we're making major updates to this. And so there are at least 2 more update cycles that are planned, with more metrics to be added to this, with kind of corresponding decision aids for each one. And I don't know if, Joe, if you're able to join, if there's anything else you'd like to add. Okay,
Great.
well, with that, I think that was a very, very quick overview.
That is,
this is a really nice site, a lot to it.
I know you're getting a lot of hits on that. And our hope is that these decision dashboards will be usable by all of our coalition members and many of our state and local government officials as well. And it's just really, really gratifying to see how this work has come together through so many strands of the different work groups in the coalition. So I just want to say thank you to all of our panelists. Thank you for the work you're doing for our communities, for our states. Thank you for keeping our healthcare system running. We hope these are some best practices that can be taken back to many organizations around the country. And thanks for your willingness to share. And we know after today's conversation, you'll probably get a lot of requests for more information. And thank you in advance for that. Next week, next Friday afternoon, we'll be having a panel on racial disparities and in the COVID pandemic and the effect on our social and physical health of our communities. We have a very dynamic panel set up, and we look forward to having all of you back and tell a friend to spread the news. Thank you and stay safe.